right. Welcome to another episode of Health, Wealth, and the Ultimate Self. We have a special guest here, Dr. Nate Keiser, up in Chelsea, Michigan. Welcome. I'm going to let Dr. Nutt here do the intro.
So Dr. Keiser is a doctor of chiropractic, board-certified chiropractic neurologist, has a couple of extra letters after the name, Fabbir, Fellowship American Board of Brain Injury and Rehab, specializing in non-surgical, non-pharmaceutical treatment of dysautonomia, traumatic brain injury, and movement disorders. In addition, Dr. Keiser serves as an assistant professor of clinical neurology for the Carrick Institute, which is also where we did our postgraduate doctorate education in neurology, clinical neurology. And that's actually how we met, right? We came up there. It was a little colder than it is here in Dallas. And
well, yeah, you got t-shirts on. I got a sweater on. That feels about right. So
yeah, and we were giant babies about it when we were up there, and that was like
I think I wore my jacket the whole time.
6:30, getting the coffee to drive over to the clinic. We were
turned the heat seater, the seat heaters on immediately.
It was mid-October. So
yeah, right.
So that course was
the way we like it up here.
That course was specifically on dysautonomia, and it was a grand rounds. We saw, was it five dysautonomia cases, workups, where you took them through examination. We'd had discussion and started talking about treatment, different types of treatments that would be potentially beneficial for these people. And we just thought, man, this would be a great idea to have Dr. Keiser on the podcast to just talk to us about things that, the cutting edge, literally like the leading edge of dysautonomia, and how these people, every single person that was up there had already seen 3 or 4 neurologists and 3 or 4 ENTs or 3 or 4 cardiologists or 3 or, just the list of providers and labs, stacks of paperwork of things that you had to go through. And then, after doing an exam, it was like, here's things that we can do to help, things that haven't been done. So, first question, I guess, would be, how did you really start specializing in this? How did you get really, involved into the dysautonomias?
Or even like functional neurology, I think.
Start from
what made you pull into
your storyline here?
Yeah, functional neurology, as you guys know, is like a very, it finds you, I think, more than you find it. I think so. I was going to Michigan State University at the time. I was in my last semester, so I was like almost done. I had life planned out going into prosthetics and orthotics. There's a big prosthetics company here in Michigan that I'd already had an internship with, and they were going to send me to grad school for that. So that was all set. But I had a friend who was sick, and this would have been early 2000s. That ages me a little bit, but so internet wasn't awesome internet at that time. But I was looking around trying to find a way to help this person out, and ended up coming across this PBS documentary thing that you had to send away, get the VHS tape. I didn't really know how to buy stuff on the internet at the time, so I figured that out, and then prayed they send you a tape a month later, and then. But it was Dr. Carrick, who we know and love, and that's the reason we're all here. And there was a vignette of these 3 cases, and they were just I watched it and was just awestruck by what I saw, and I was in at that point. So I changed my whole life around. Looked up where they were teaching his stuff. He wasn't teaching at the time. He had people teaching for him, but they were doing it at Life University in Atlanta. So I was like, that's a flight from Detroit. So I'd never even been to a chiropractor at that point, but that's what he was. That's what he did. So that's what I did. And so yeah, went down that road. Went there, immediately enrolled in that program, and that was my whole life for that period of time. And then, so then practiced privately on my own for a while, and then had the opportunity to go work with Dr. Carrick. Well, before that, got the opportunity to teach with Dr. Carrick, which was great. And then got to go work with him, which was for me, changed everything. It was you know, like the scales fall off your eyes, that sort of thing. And it was, yeah, I just got to see all these cases that I would have never been exposed to otherwise. And they were people that I looked at and like my heart hurt for, because I was like, I don't know what we're going to be able to do for these people. But Dr. Carrick would, you know, do his magic, and then like they'd get better. And so like I just got to do that so many times with cases that I didn't know how they would turn out, but he was there to guide that whole thing so much that like it became normal. And then I understood how to do it. And then it just kind of kept snowballing from there, which was like the biggest gift, because they were just cases that I wouldn't have felt like I knew what to do. But working that through and having him there and kind of like teaching all along the way made a huge difference. And then, you know, so a lot of what we were seeing then in Atlanta was a lot of TBI. This was after Sidney Crosby. There was this huge hockey push. There was all of this media attention around what we were doing that was really, really amazing. So we were seeing a lot of people that had concussion, traumatic brain injury. And you started to see this overlap of concussion cases that had this extreme tachycardia. And you would see it relative to blood pressure changes. You'd see the tachycardia. You'd see all these things that we understood on a functional level relative to brain output. And you'd see them improve, but then you would also see these cases that were like slightly different, where the main origin might not have been a TBI per se. And you started to see these cases where it was like slightly different. So I started to get interested mostly because like we were figuring out how to solve these cases, and they were post-viral cases. And then you'd see kind of other cases where we were so used to looking at these are problems within the brain and solving the function within the brain. And then we would see these autonomic cases improve. And then like, as we did that, like we got a little bit of a reputation for it. And then they got harder and the cases got more complex. And at that point was when I had to start expanding the scope of understanding what was going on and do it at a deeper level. And that's where I started teaching about it with the Dysautonomia course. I spent years putting together mental models to try to understand how to think about that in a better way. And then that's kind of what I shared in that course. And then doing grand rounds is really the way to learn it, because then we're kind of doing it together and understanding like how we're thinking about it.
For sure. Awesome. It shows that it took years to develop that, and you know, the knowledge that you gained from working with Dr. Carrick, and then taking that and doing, you know, creating your own type of program, creating all these other things and creating the education. It's like, you could tell it was years of effort and years of knowledge being put into that amazing, you know, 3-day course that we did up there. And it's just like,
just the way you kind of talk through cases in terms of like, hey, you know, here's the symptom. What are the potential, like, you know, kind of pathways in and out that would, you know, be our differential to play through. Why is it not this? Why might it be that? Like, that really speaks to my brain and how kind of it ticks. It's like, okay, like, because again, then it comes back to like, well, how do we get and talk to that part of the brain? How do we influence it to change function? And that's the cool part, is kind of going into, I think we're doing through like, hey, would we do post-auricular like vagal activation on this person? You're like, no, just because it wouldn't really hit that part that controls this. And when you look at your setup, which would be really cool if there's a way of like just screenshotting that. I don't know how. I mean, I try to take a good like picture of just like the continuous blood pressure cuff, heart rate monitoring. That is so cool, watching like the transcranial like blood flow, and kind of how you can use that to, again, have a like level of like longitude of where potential issues are. And then again, pairing that with an incredibly thorough functional exam. That it was really awesome to see. And then Freddie, I mean, he was talking you up a couple of weeks before, like, no, you guys got to come up to Michigan. Like, you need to see this. And I'm so glad, because I think it was like 2 weeks before.
Yeah, we
had Pain Reset in Dallas. He's like, no, you got to come up. And I was just like, guys, like, we should go up. We should do this. Like, we got a lot going on, but we need to, like, just kind of make it happen. And it was definitely glad we did.
Yeah, it's been great because, like we were talking about before this, it's like once your brain starts thinking about something, all of a sudden these patients start coming into the office. And I swear after that 1 weekend, I had like 3 or 4 phone consults of like, my 18-year-old daughter passes out every time she stands up, and she's seen 15 cardiologists and neurologists and all these people. And it's like, okay, well, let's do a more thorough tilt table testing, or let's look at autonomics a little bit more. Let's figure out why the anxiety and why the blood pressure and why the GI problems and why, the insomnia, why those things are all tied together, and not just try to do 1, 2, 3, 4, 5 different medications to try to adjust how her body is functioning. And, one of the things that was funny, because I think of the 3rd or 4th patient that we were seeing, all of them are like, are you doing any salts? And they're just like, oh, I just drink salt all day long, all day. And it's just like, and then we had a discussion about how that, initially it works, but then it kind of fades off and it doesn't work so well. And it's just, you could see the education, these people's eyes just kind of like, there's hope. And I think that, that's a lot to talk about there. It's just like patients having this ability to feel hope for the first time in a long time after this incredibly thorough examination where they haven't had anything like this done before. I mean, tilt table testing is pretty common. They'll get the diagnosis POTS, but then with this intracranial blood pressure monitoring and blood flow monitoring, it's like, oh, actually you don't have POTS, or actually, it's really not that bad, and it looks like this vagal nerve problem is, or this or that. The diagnostic testing is unbelievably
just differentiate where the problem is, I think. Yeah. Cool. I mean, the other aspect that I think was really, and again, from being, in the functional world, and again, seeing, when you're going through 5 patients or 5 workups in a 2-day span, you would see a finding on the neurological exam or on the workup, and then you kind of like, hey, if you do this, how do you feel? And it's like, you could see their eyes kind of like, hey, why is he asking me that? How does he know I feel that? But again, because of your understanding of the neurological finding, what part of the brain controls that, I think that's the cool part, is like, you're just starting to string and connect a lot of dots that really are still from a common problem. Yet, tradition, I think healthcare isolates them, like, oh, anxiety is separate from, the tachycardia. It's like, but is it? It makes sense that they cluster together. But anyways, what, so dysautonomia is kind of where you got this, big niche, the education. You can definitely tell that you poured your heart into it from just seeing how your workup is. Any other, what causes it? What do you see as like the biggest thing that is the linchpin, or is it many?
I mean, that's the question everybody's asking right now, and it's the right one. The way I understand it, the way I put it, I like to think about things through models, through frameworks, in terms of how do we arrive there. So in some cases, like as we've seen in the last few years, so prior to 2020, the majority of people that I saw with autonomic syndromes were mostly relative to some type of head injury. And then there was a smaller portion that we saw a pretty common etiology after a major infection, right? So like those were the 2 big ones. And then you have this overlap with Ehlers-Danlos syndrome, but there's a catalyst to that. It's not like they just wake up one day. There's typically a catalyst. And then with COVID, we really saw a rapid shift in that balance where for probably 2 years, it completely shifted. Like most of the people that we saw were relative to a post-infectious type of a dysautonomia. And that was really important. And I think it's really important because we label things as POTS. Like POTS is the thing that people know about. postural orthostatic tachycardia syndrome, POTS. Whenever there's tachycardia, that is kind of like the direction people get pushed in. And then there's an algorithmic process that they go through, and it's usually medication based, along with, you know, getting some tight socks, some compression garments, and, you know, and salt. And that is the primary tool. But I think what we miss a lot of times is the origin, like what happened and what is actually wrong. And because of that, we miss all these other diagnoses that are more applicable, and they actually tell us like what to solve for. So you might see somebody that has a true like sensory vagal neuropathy, which was common in post-COVID, where people get vagal neuropathy or laryngeal neuropathy that goes with it, you know, so like you got a vagal component, and then, you know, they don't speak very well, and then we get the tachycardic problem. And that's different than if somebody's got something that, like a Guillain-Barré, which was also really common, where you're just losing peripheral nerve function, getting demyelinated, and people just couldn't create tension in the vasculature in their bodies. So it's like they're walking around with all this blood pooling to their feet, and they can't get it back to their heart. But these are two wildly different problems. Like, yeah, they're both peripheral nerve related, but you wouldn't solve them the same way. So it was just, it's come a lot of like maybe asking the deeper question, like, okay, you've got tachycardia when you stand up, that's fantastic, but like, do you get blood flow to your head? Do all your nerves work? You know, is your brainstem running all right? Are you also having problems with anxiety, or are you noticing like thermoregulatory problems? Like, how do all these pieces fit together? And as you know, I mean, functional neurology, we just got lucky to like have those two paths cross and have them cross at the time, because functional neurology allows you to say, well, where is it? And make it a lot less of a complex problem by just going a layer deeper than people are used to going.
So with, you know, to play devil's advocate here, how does someone who knows a lot about the brain affect something that's post-infectious? Like if let's say I had COVID, or I had Epstein-Barr virus, or I had mold toxicity, or like a lot of the major infections that are commonly associated with developing these types of dysautonomias, how is affecting the brain going to affect that nerve, like affect that immune system response?
That's the question. So number one, when we think of post-infection, I think the post-infection part is important, the post word. Because we want to step in and be able to solve a problem, we're using training, we're using a neuro-rehabilitative model. And because of that, we want to make sure, like, to use a reference that you guys would probably be familiar with, like if you think about a hurricane coming through, you know, it's going to tear some stuff up as it comes through. There's damage afterwards. You don't want to be trying to rebuild everything during the hurricane. You want to like do your best to solve that problem, or let it pass, or whatever comes of that. So you don't want to be like in an active acute line trying to do neuro rehab. Like, it's just hard to get any traction. But once that's gone and you're post-infection, it's exactly that. It's cleanup. It's thinking about what is working here, what's not working here. And we know at the core of this, your entire immune system is controlled through brain outputs. So you have to be able to have the sensation, like the messaging system that talks to the brain to say we need to mobilize this immune response. So even when you think about just healing on an immune perspective, you have to be able to have messenger systems communicating with the brain, and then have the outputs be able to match that appropriately. We see a lot of post-infectious autoimmune problems, which is, to think about it in a slightly different frame than maybe would be common, is you're having a signal that we need an immune response, but the immune response is so big that it attacks its own tissue. So we end up with, you could consider it like a hyperkinetic immune response. It's too big for the amount of activity that we should be expressing here. So we have a mismatch. We have a mismatch between the sensory input and the motor output. That is largely a signaling issue. where we want to think about, well, are we interpreting correctly, and are we getting the right outputs correctly? And then you can extrapolate that and look at it similarly, like if I've got a nerve that's chewed up, if I've got an area of the brain that's affected. There's this gal from Cal, I think it's UCLA actually. I think her last name is Beckman. She has these beautiful slides that she'll post on Twitter where she's actually looking at the way these infections infiltrate a neuron. And it's going, through the olfactory bulb into the olfactory plate. And she has these beautiful images where we're seeing how they infiltrate into a neuron. And we want to be able to come on the back side of that and be able to get that neuronal structure to be able to fire again. To build a neuron, you have to stimulate, which I think is fascinating, that you can't oxygenate a neuron back to life. You can't glucose a neuron back to life. Even though they're the building blocks, the foundations of life and of a neuron, you have to stimulate it to be able to pull those things in, to be able to make it grow. And I think that is really where we're lucky to have come into this world at this time, with that just a little different window into things, to be able to say, oh, like stimulation is really the way that we solve a lot of these problems, and being able to stimulate it in a rate that people can tolerate and they can use and they can build from, really makes a huge difference in my view of it.
Yeah, I think that's the biggest thing. And kind of piggybacking on the need to stimulate, because I'm sure it's the same with you. Like maybe they've done OT, PT, like neuro rehab, and and I think that's the one thing, like explain to them, like it's kind of very non-specific in terms of what they do. Like, hey, we're going to do some VOR, but it's just not trying to get and talk to a very select circuitry in the brain. It's kind of like shotgun approach. Like we just hope we hit something that might help you. And again, unfortunately, we see the ones that definitely doesn't usually work and help. Yeah. I think kind of when you talked about, so you wouldn't treat or work with and do rehab on the acute Lyme patient. What do you feel like? Because again, when you have that person, like, I know what this is, you have this kind of fire going on. I know we can help you, but we got to get that fire out. Like, kind of how do you coach that patient through that moment where, like, look, we're going to help you, but we kind of have to get this under wraps? How do you word that? How do you kind of give them some expectations on how to kind of walk through getting back to you to start the stuff that's going to get them better?
Yeah, I mean, that's where the multidisciplinary component really matters. And if you can look at any case and go, I don't care how we solve it, let's just solve it. I know that my specialty is, I really am passionate, the way my brain understands the world is through rehab. So I know that that acute stage of Lyme, that's not where my skill set is. So I work with other people to say, okay, we've identified this as being a problem. Let's go over here. Let's put this fire out. Let's solve this problem. And then as the dust settles, if you still need me, that's the time where we can look at the rehab again. That's where we look at getting stronger. That's where we look at it rebuilding. But, I really lean on other practitioners in a lot of ways to be able to solve those problems that, somebody else has put. If I think about how much time I put into my part, I want somebody that's done the same thing on that. And then let's find those people and let's use those people.
Absolutely. Yeah. No, and that's what I noticed on your website too. It's like one of the things that you put is just like honesty. It's like one of the when you scroll down to the bottom, it's just like, I'm just going to be straight up honest with you. If I can help you, I can help you. If I think you need to see this person or this specialty or this, you're treating them not as a number or demographic. You're treating them as a family member. You would hope your mom or your dad or your sister or your brother would be treated the same way. And I think that's that's also something that really helps separates people in our type of model, where it's not like time based, but it's just what you need is what you need. And I'm going to sit down and we're going to do a 2-hour exam. We're going to sit down and take if you're starting to feel nauseous or something, I'm going to go let you lay down for 10 minutes and I'm not going anywhere. We're going to be able to sit and talk, and we'll do, maybe some little therapies to make you feel a little bit better or something. Well, we're not, okay, hey, how you doing? Dysautonomia, POTS, here's this medication, salt, socks, get out of here. Like, I think having that approach is what's needed more than ever. Just like you said, these post-COVID and post-infection patients, I alluded earlier, I had 4 or 5 calls, and all of them, with the exception of one head injury, were all post-infection. And it's like, it just shows you the need is absolutely skyrocketing right now.
It is.
Post-infection, Mexico picked something up.
Mm-hmm.
Yep.
Again, like, it was similar to I think the second or third patient. Like, you could just tell, like, where her shirt was just rubbing on her skin from, like, who knows, hour earlier, was still, like, just screaming red. Guys, like, do you get itchy? Do you get red after the shower really quick? It's like, oh yeah, like, so, like, it again kind of started going through, how long has that been going on? And you start like, oh yeah, it happened like 2 or 3 weeks after I got sick.
Mm-hmm.
And it started to really get bad. Like, she's like, I'd have minor flares. She's like, but why is that important now? It's like, again, like, something you went through had a systemic effect on you. You're here. Like, when she stood up from our waiting room couch just to come in and kind of go through our, consult. I mean, again, like, I thought we were like, her sister is dedicated to basically help care for her. And, she's 22 years old. And I can't imagine how that life's going to be. Just for the last 2 years, it's been medications, and that's kind of it. And there's so much more that hasn't been touched yet on her. And again, it's like, there's such a big infectious component piece that hasn't even been, like, opened up.
Okay. Sorry about that.
You're good. All right.
Thought I was going to get.
So tell me, what's that? Can you hear us okay?
Yep. Good.
Tell me a little bit about your clinic in terms of, hey, somebody gets, they're got a concussion, post-viral, they're having dysautonomia. Like, one, what should they expect? Like, hey, I want to go fly up to Michigan, to Chelsea, Michigan, see Dr. Keiser. Like, what's that process look like? Is it, they expect to spend a week up there? Do you do kind of, how does your treatment and everything look?
Yeah. So on a broad scale, we see people from all over with a lot of, like, different ways that they got sick or they got injured or whatever it is. So we work really hard to try to make sure that we don't try to algorithm people. So we try to look at it as, like, we're just going to problem solve, and whatever we need to do, we'll do. But a lot of people come in from further away and need to be like, I have to plan something. So we usually have people plan to stay for a couple weeks, sometimes more, especially if they're crossing an ocean. Sometimes we'll say, plan for a little bit longer, just so you don't have to fly twice. But usually we have a pretty extensive workup. We take a lot of time on the front end. Most of our tech happens on the front end, where we're trying to solve the problem. And then once we do that, we're trying to solve for whatever's going to be the linchpin to be able to move forward. And we do a lot of continual diagnostics when we're doing that throughout their time here. We usually have people stay for a couple weeks. We usually see them multiple times in a day. And that's the way I prefer to do it. I prefer to try to isolate as many variables as we can, try to limit all of the other components of their life that would kind of make the results wavy, so that we can understand that person really well. And that works for us. That's the way I like to do it. People that are more local, we handle it a little bit differently. But we see a maximum of 6 people in a week. So, like, we don't see a lot of volume. I have a staff here that is amazing, that and they're really like a dialed in team. So, like, we work at trying to see a very consolidated number of people, and we want to win every case. So we have a pretty deep screening process where we go through a lot up front to make sure that people are going to be a good fit here, because we want to be able to focus on people that we know that we can do well for. And a lot of times that means we end up, on the front end, meaning like, hey, this might not be your thing, but let's see if we can get you to someone either, closer to you or that specializes in this, or let's move down this path first. That might be a better solution for you than making the trip up here. And we try to do that. I feel like that's a win just as much as if they come here and we're able to help them here. So wherever we can get them to, that is the right move. We're just trying to win. We're trying to win and do the right thing, make sure we do the best thing to try to help somebody out. And if that's here, great. If it's somewhere else, great. We have, we're blessed to be able to serve a lot of people. So we don't have a shortage of doing that. So our incentives are aligned. I love that actually about this line of work, is that we're like, as a practitioner, our incentives align with the patients, meaning like, you have to do a good job. If I don't do a good job, people just won't come.
Yep.
And that's it. But if you do a good job, the patient feels better and you feel better about it. So like, I love that those incentives line up and that we're both heading in the same direction. It's not the type of thing where no matter what I say or do, no matter how good I am or am not, I'm still going to have a full book of patients tomorrow and the next day and the next day and the next day ad infinitum. I like that the results are tied to the practitioner and the patient at the same time. So I think that's the way it should be. So I like that that's the game we get to play.
I think that's so accurate of kind of this profession is, unfortunately a lot of it isn't covered by insurance, and a lot of it is,
Right.
a lot of it is going to be just a cash pay practice. But, a lot of people look at that as a negative. And in my mind, it's like, well, if you had to pull your wallet out and pay what your insurance is paying for your 5-minute visit with this person or that person, like you would refuse. Right. And it's like, but if I told you it's going to be X amount of money and I'm going to over deliver and under promise and absolutely knock it out of the park and let the cream rise to the top, when it comes to how good we are and how good you are and how good, your process works and how specific it is to somebody. I think when you have the passion to help somebody, and when you have the time to stop and the knowledge to stop and take care of someone really well, parents and people will pull out their credit cards and spend $1 million to feel better, because at the end of the day, your health is the most important thing to you and your family. So, and having an ability to say, you know what, I can only see 6 people a week, but out of those 6 people, almost all of them, if not all of them, are going to be better, on the right direction, and feeling well. And that's how, I know how your practice works. And I know that's how our practice works is, we're just going to do what it takes to make you feel better. And we're going to spend the time to make you feel better. We're going to do our own research and do what's necessary to make the difference that maybe someone else is overlooking, or have these different specialties who are looking through just that specialty lens as opposed to looking at the big picture. And I think that's what really makes these types of functional practices so important right now. And that's why in my mind, like, in your practice as well, the referrals are just coming in like crazy, because it's like, if you do a good job and you do something that no one else has done, people are going to make a referral and say, I don't care how much it costs, I got to see this guy, or I got to see this person, or I got to see this provider, because they care and, they spend the time and they do what's necessary. How, starting off in practice and, did you ever do just like straight chiropractic, or were you always into the just straight out of the box, like straight out of chiropractic school? I know you basically got the diplomate right out of chiropractic school, and basically had the wheels running as soon as you graduated.
Yeah, I mean that's what I went to chiropractic school to do, is to do neurology, and that was, so I started there. yeah, from the beginning, naively. I got to experience really early the fact that like, if you don't do a good job, you can't survive. And I was really lucky. I started practice in Nashville, Tennessee, and I had these two chiropractors that had been in practice for a long time, like 30 years, that really, really got me going. They basically got me an opportunity to speak in front of the Tennessee Chiropractic Association, which I didn't have anything. I didn't have two nickels to run together. I was like, you know, do I put gas in the car or eat? Like, that's where I was. And they got me in front of that group. And I just got really lucky that I was able to speak. I ended up seeing some family members of chiropractors in Tennessee. And at that stage in my career, they happened to be cases that were just like built for the knowledge base I had at that time. And they did well, and things grew from there. And it was like, you know, there was obviously a hand in it other than mine. But that was just the way it was. But it taught me pretty early on that like, if you work harder and can do more for people than anybody else can, things will work out. And so that's been the game ever since. I mean, we, wake up every morning. I read for a couple hours before work. I read papers before I go to bed. I think about it constantly. And every day is just like trying to get a little bit better. And hopefully, hopefully someday that's where it should be, but just trying to keep moving forward and doing that over time has brought us here. So
I think that's a good point, is just, I mean, like, you always feel like there's just more knowledge out there that you could pull into your patient, and like, it's just this, I want more time because I know there's more information that I can bring to this case, and it's just constant. And I think that's the other aspect. Like, I think that's really important from a healthcare and being a good provider, is knowing that you may not have all the answers, but you understand like, hey, if I can't find it, and I think that's one of the best things about the functional like neurology like community, even the functional medicine, like, there's a good like camaraderie. We're like, hey, I don't know it, but like, I'm going to reach out to Dr. Keiser in Michigan because maybe he's a better fit. Because at the end of the day, we're advocating for these patients to get well, and whether we make the referral up to you or you make the referral to Florida, like, or vice versa, like, when that person gets better, like, what we do as a team sings louder, and it's like, gives it like, hey, this works incredibly well. And and that is the cool part, going and seeing like how specialized you were in like the dysautonomia. Like, oh my god, man, like, I would love to go and buy that and do that workup. It's like, okay, we got a big shopping list over the next little while, yeah, and maybe we need another 1,000 square feet to do it. But again, it's just like, prior to that weekend, that wasn't even on the scope. Now you come back and it's like, you bring new things to practice, and it just, you never stop learning. And I think that's the one thing, like how, one thing, kind of like stresses me up, but like kind of like rubs me the wrong way. And it's hard to not like show emotion, is like when, another provider, let's say a patient you're seeing is like, oh no, just kind of completely like, this is what it is. It's just POTS. Like, there's nothing else. Like, it is POTS. Or they just kind of they want to like make it very simplified, but it's much more like, there's more to it. And I feel like that's one of those things that like just kind of disenfranchises like the patient and their ability to get better. We're like, yeah, no, it's just that. Oh yeah, you're just going to be like this for the rest of your life. And yeah, it hurts for the
there's a lot
patient.
of that right now.
Yeah. I understand. Yeah. I mean, again, when you don't have much time to see them, I get it. I think that's the neat part. And then too, I think you mentioned something a few minutes back where, as you're working through that patient, like, there's a constant re-examination, like, throughout that day. Like, you may see them 3-4 times in a day. Like, how many things are you kind of pulling through and reassessing on a given patient? Is it, hey, we're going to go back and check saccades? Like, do you pick a handful that you think are the most significant, or 1, 2, kind of, how's it work?
Yeah, that's a good question. With our team, basically what we've done is we take out all of the salient findings, and we have those listed out and we're hunting them the whole time. It's like as we're looking through every encounter, in between reps, we're checking things, and we're looking to keep moving the needle across all of them. So we'll carry them through. Maybe it's a handful of things. Maybe it's one. It depends on the case. We're looking a lot of times. Let me say it this way. So one of the things I learned from Dr. Carrick is to develop your toolbox, to have availability to turn to any tool that could be used. Know them all. Try to learn as many of them as you can. And then also be diagnostically accurate enough to try to pick one. So the tendency when you have a lot of tools is to use a lot of tools. But a lot of the people that we're seeing, because the autonomic system is affected, their capacity is low. Their ability to tolerate stimulus is so low, right? Regular life, just sitting on the couch is too much stimulus for you to not have symptoms, right? So like the capacity is so low. So what that really is saying is we have to be able to hit a dose of an exercise that is below that capacity and to be able to build it up. So the more things you throw at someone, the more stimulus that you give them, you're pulling on that battery, you're draining that battery in a way that if it's not going to be useful, you're just draining the battery. So that was a humbling thing to learn from him, was have a giant toolbox and know which one tool is going to work and how do you use it in a way where you're not exceeding their capacity, but you're helping them build it. And I don't think I hit that. I don't get that right every time still, but that's what I'm striving for is when you guys see, I used a ton of equipment, a lot of diagnostic equipment, a lot of technology early on. But when it comes time for treatment, I'm usually using something that is like, monkey with a stick simple. That's on purpose because I'm trying to do something that fits what a human receptor was built to withstand, and use the things that as humans would be the way that we interact with the world and build from there, starting small, super small.
I mean, people walk into your office, over your shoulder on there, you got this big, crazy, beautiful machine. We have a crazy big machine. They come in like, oh, when do I get to jump in that? Like, and again, it's like, hey, that might not be the best tool in the toolbox. This might be the most shiny. And a lot of times you have to kind of like, that looks great, but hey, it's not therapeutically, we just don't think it's going to be the thing that delivers. It might be, like you said, the thing that a monkey with a stick can do, but doing it very accurately is what changes them. And I think that's the part. And so I think that's one of those things where you always kind of have to like, this may not seem like much, but we're going to do it and watch the changes, repeat, reassess. I mean, for our listeners, like, kind of going back, we're talking about dysautonomia. What is, if you wanted to kind of just to the layperson, like why is the autonomic nervous system so important?
Yeah, I think it's the foundation for the way our brain can operate, because it effectively, it delivers the fuel for anything that needs to work. So you can't operate without it. If you want to, it connects your ability to be able to deliver oxygen to every cell that needs oxygen. So if you've got a cell that has to metabolize, it has to work, it has to be connected to the autonomic system. So for me, starting from that point makes it obvious, like that's got to work if I'm going to do anything that's complicated. If I want to run anything in my brain, anything in a muscle, anything in an organ, it's connected to the autonomic system as a primary means to be able to deliver that. It's my first principles in the way I think about it. And I think that's because I put so much bonus on it is probably why I specialize the way I do. But just learning your complexity is limited by your capacity to deliver fuel. So if you want to do things that are the epitome of being a human, the majesty of being a human, we take for granted that that's going to work, that autonomic system is going to work. And there are so many people that when that fails, it really steals your humanism. It steals everything about what you're accustomed to in life. And I think if you can get that system back online for people, it's, it's life-changing. There's nothing better. And so for me, that's first principles. If I'm going to do something complex, I have to prove to myself that all of those things are intact before we go to that level. And that started with me in concussion, in TBI, in brain injury, and it's carries forth into the way, it's just baked into the way I think about health.
So kind of, in terms of the autonomic system, then what would be kind of, hey, if somebody's listening, signs that they may have dysfunction or dysautonomia or some abnormality in that system? Like, because again, we talked about POTS, but again, it's not just POTS. Like, there's a whole host of things that can manifest when the system we take for granted goes awry. Because I think we don't think about how our hand grabs something, but how we actually get the fuel to it. It just happens. And it's like when that doesn't happen, the proverbial crap hits the fan. And again, it's pretty alarming to that person when it does. So what would be kind of clusters of symptoms, or kind of somebody might be feeling that they might actually be dysautonomia, or the starting of it, or full-fledged?
Awesome. So first of all, I think one of the key things that that it really helps to understand is your autonomic system is organized functionally, meaning most people will think about like the next layer of understanding autonomic systems is like, there's a sympathetic system and a parasympathetic system, and these describe two different types of nerves. But even within the sympathetic system, there are different things that are happening. So the part of the system that controls heart rate actually is slightly different than what controls blood pressure, but they work together, which is cool, but they're not exactly the same. And the part that controls sweating, which they can work together, isn't exactly the same. Controlling temperature, not exactly the same. Controlling digestion, not precisely the same. So it's actually really useful. So the same way you could look at someone and say, like, they can move their fingers, but when they go to walk, they're ataxic. So it would tell you, like, this isn't a problem, right, in that particular part of the brain. It's more relative to what's going on in the lower extremity. Same thing works in the autonomic system. So you can think about, do I have symptoms relative to my heart, in the way my heart beats? Tachycardia is going to be common with that. Do I have problems with my blood pressure? So maybe my blood pressure is too low or too high. Easiest way to think about that would be to look at, do I get lightheaded when I stand up? Do I feel foggy when I'm up and moving around do I feel better if I lay down? Those are really good indicators. Digestion is a big one, and it may correlate with heart rate and blood pressure things, or it may not. It may be separate. But if your digestion is too slow or too fast, things to think about. A big one is like being able to tolerate heat. You guys live in Texas, you know the deal. So a lot of people that have autonomic syndromes don't tolerate heat very well. They might not sweat. They might sweat too much, but they know they don't like it. They don't like getting in a hot shower. They don't like being outside in the heat. Circulation we kind of spoke to. But those are like the big core elements. And then there's the general stuff of like, just feel gross, you feel foggy, you got the headache, like the things that are hard to peg to any one thing. You kind of put those in a cloud over here, and then you're going to try to understand that through the lens of the other things that are happening with that. But all of them kind of generally create this, what's been called in the research called sick behavior. It's just things that like generally go wrong when we're not operating well. So kind of, looking at those different elements are a very good way to boil that down. And a lot of people will check off a lot of those boxes at once. the more those things become centralized to the brain.
Why do you think post-infection and concussion can cause similar symptoms?
Oh, love it. I think they cause similar symptoms because the people that we're looking at that are post-infectious are people that have neurological based infections. When the examples you gave are all things that we know go to the brain that have neurogenic transmission that actually transmit through a neuron. And then you can also tie in the hypercoagulability that can happen, particularly relative to COVID. That's like the two worst combos, right? So you got an infection in your brain and your blood's sticky. That makes it really hard to be able to shunt blood around, so like it doubles down on the problem that's there. So yeah, I think that is the overlay is infection and brain injury. You're looking at the same tissues being affected.
Like that's kind of explaining to a patient, like, why is my brain not working well post-COVID? It's like, physical trauma caused an injury or your traditional concussion, like one's more chemical or biochemical in nature that pulls the immune response, and it's still a traumatic response potentially to select regions of the brain, right? I mean, it changes function at some level. And again, it may not be a punch to the head or a soccer ball to the head, but it's still a viral infection that had a cytokine response, a microglial response, vascular responses. I mean, again, it's harder for them to, I think, see it or kind of extrapolate it, but I think we got to do the best as we can to kind of make them realize it's just as important to have it addressed versus the physical concussion.
Mm-hmm.
Yeah, two different types of trauma, but it's still trauma, right?
Well, and kind of going into that question, like, you have kids, and people ask us all the time, like, I think, you're talking about playing hockey. We both play contact sports. Like, would you allow knowing what your child to go play contact sports? I know. I say, I'm like, yeah, I would. Like, I know I'll probably be more I'd be baselining a bit different than what I did. Like, the definition of concussion is completely different. Like, I think, I've had one documented concussion, but you think about it, it's like, it's probably much more than that. But again, like, knowing that you can have these chemical things out there, viral infectious things that are just probably harder to kind of avoid than the physical trauma. What do you say to somebody then? Because I think that may change people's approach. Like, are you going to live in a bubble, or are you going to live your life, have fun, and just kind of what would you say to somebody asking you that question? Like, would you let your kids play a contact sport?
Yeah, I get the question a lot. No one's ever framed it in the way of looking at probability of a traumatic injury versus the probability of infectious injury. I don't think anybody's ever put it to me that way. So I think that's interesting. And I think you're probably right. I have a son. He plays hockey. We didn't push him to play hockey. He loves it. And I grew up playing contact sports, and I loved it. I got hurt playing contact sports in a way that most of my patients can identify with. So I understand that side of it too. And I think you're right, is you could look at anything and look at the downside for sure. And it's there. And I don't know the right answer. I don't know if keeping them out, maybe that would be better. I don't know. But I also know I don't want to keep them from living the life either. And I took so much away from my experience with sport. I think about, like, I talk to you guys, like, I get up every day and I read about neurology for like a lot. And then I go do it all. Without learning how to discipline myself through sport, I don't know that I would have the capacity to do that otherwise. I mean, I'm not that altruistic. I just know, like, I learned how to practice, and I just do that with a different sport now. So I don't think I'd ever try to take that away from them. But I'm very conscious about how they play the game. I'm very conscious about what happens to them in the course of the game. I watch probably different than most parents do. And we're lucky to be able to be in a position where I have the ability to do something about that if something does happen. But you know,
Yeah,
same thing at walking to school, the same thing could happen going
slipping
down
on
the stairs.
ice.
Yeah.
In the
Yeah. Majority of concussions are still not sport related, right? They're still slips
Exactly.
and falls or stuff falling on your head or just accidents. Bathrooms are dangerous places.
Yeah, I mean,
I think that's a good way to think about it. Yeah.
well, and then even just going back from, when somebody comes in wanting rehab, you're delivering sensory therapy in some way, shape, or form. And again, I think of, when you're playing a sport, there's so many benefits that can come from it, like the discipline, like to show up to try to get better. Again, at some point, especially when you get competitive, like you're really competing against yourself to move yourself, stay relevant to the team. And so there's got to be this inner drive, which if you don't have that, what's going to make you stay up at night to work to help a patient out or to solve a banking equation, you know what I mean? Like you have to have this internal drive to be better. Like we know from psychological models, like external motivation only goes so far. There's got to be this internal motivator. I think sports give such a valuable push for that. But then you step back and be like, are you healthy? Are you going to live 10 years longer? Because conditioning and exercise also has become a habit that, I know if I don't work out, my wife's like, you're getting grumpy, go to the gym. Like it's neurologically wires your brain differently. The sensory aspect, the fine motor control, like there's so many aspects I think too that are positive from it. And I think, obviously concussion is a negative thing, but again, I think there's so much positive that comes from moving, and whether it's through a sport, running, again.
Not to mention like the socialization and the.
I've thought about this a lot. You've answered this question a lot. Yeah.
I mean,
good. I mean,
yeah, ask all the
it
time.
as a net. I think you're right. Yeah, I think that's a good orientation to have.
I mean, because like on the functional medicine side of the equation, people come in and they haven't had a life of exercise or sports or kind of they haven't really moved, like it just wasn't something that they were brought up with. And they're like, you'd be like, hey, these are some recommendations, and they're like, do you think exercise? Like, I don't know. I'm like, I just think it's such a barrier sometimes. But I'm like, and I kind of feel like, man, I'm blessed that my family kind of allowed me to support me into being movement oriented from the time, like I feel like when you're born up north, you come out with skates on your feet. But I feel like it's just one of those things, like, again, just very fortunate to always have this like foundation of just whether it's baseball, movement, and hockey. Like, it just feel blessed that that's there. Because again, when I see those people that come in and they don't have that foundation, I just like I don't think there's medicine as good as exercise and movement, like this, and then even then the social aspect on top of it. So
all great points. Yeah, I think that's spot on. You got to keep, I mean, we're bodies in motion for sure.
What, are there, and this is obviously a loaded question, but is there certain things that are like, if I were to not ever need to see someone like us, like, is there certain things that you would say, like, here's what I do on a daily basis to make sure that I don't get these problems? Like, what would you say to someone like, hey, if I, putting a preventative ideas together?
Yeah. Well, a lot of it's what we just talked about. And I actually do talk about this a good bit, is moving every day. And it doesn't have to be, you don't have to be blowing your eyeballs out with, deadlifts and squats, but lifting heavy things is really useful, and walking is really useful, and just a variety of movement, being flexible. Can you get off the ground? Can you move? I had someone, I've been a gym rat my whole life and got super competitive with it. Did a lot of CrossFit for a period of time at like over the top level. And somebody mentioned the idea of like working out like you're old before you get old, in terms of like just to keep you moving. You don't have to work out till you're achy and painful and you can't move around, but like enough workout to where it adds to your life. And that amount is not that hard to do. It's just a habit. And then just eating, like, I don't eat super restrictive diet. I've done that in the past too. I just try to eat like real food, and I try not to eat stuff that's been sprayed with a lot of stuff. We don't eat stuff that's got a lot of chemicals on it. We know that's not good. Like that, it's an easy place we can all agree on. Great. And if you can afford that, that's amazing.
Podcast before this one is about chemicals and environmental toxins. Just the amount of shit we're blasted with on a daily basis.
Yeah. So just try to. I mean, yeah, we don't exclude bread. We don't do those things. I know that some people don't have the capacity to do that. We don't, but we do eat organic. Yeah. We have a friend that makes a sourdough bread, and they only use organic flour, and we eat meat, but it's all stuff that we either shoot here or is butchered here in town, and we just try to be really simple about it and not overcomplicate it, and hopefully that's the right thing. We'll find out. But there are people that have done it other ways too, and they've gotten old. So I think there are a lot of ways to get old. Just hope to find one that works for us.
I mean, I was doing some Christmas shopping for my kids this morning with my wife, and it's like every time you go to like a bigger store, like the little motorized carts, and I always there's times where I'm like, do you need it, or is it just like a convenience thing? And I'm like, dealing with people that lose that ability to have gait and walking, and you think like there's just people that maybe you're like, oh, I just want to. I know there are people that need it, and I don't want to be careful on that, but there are people that are doing it because they're on the lazy side. They're just like, I don't want to walk, or it's fun. I'm like, again, it's like you don't realize how hard that was for you to attain gait and walking, and just to kind of hand it over so easily. It's kind of one of those things that I get like in my head. Like I'll probably always say something to my wife when I'm like, I see them, like they could walk though. Like they shouldn't give that up so easily.
If you lose it, if you don't use it, you lose it, kind of thing, for sure.
Right, but it's like
you can see that bear through, especially in a lot of dysautonomia cases. People will end up in a wheelchair, and you'll have young kids, teenagers in wheelchairs. What we've noticed from our experience is that once people get in them, it's a lot harder to get out. So if you're someone that's watching that's like in the dysautonomia track, and I really advise people to, as best you can, keep moving, even though it sucks, even though it's hard. The more of it you give up, the harder it is to get it back. And, the more you can kind of gut that out and be able to keep as much capacity as you can, it really pays off. Same reason when you take an athlete who gets a ding, who gets, their bell rung, they respond so much quicker than someone that's sedentary. It's just reality. And I think so giving that fitness away makes it harder to recover again, for sure.
Yeah, no, that's a good point. Because again, like the ones that have been active, like metabolically, they definitely respond to care differently.
How about some of the stuff that's getting really popular right now? Infrared sauna, cold plunges, all those types of things for general healthy people. Like, what are your thoughts on those?
Especially with autonomic, because again, like a cold plunge for somebody that's got dysautonomia. Like, what are your thoughts on that?
So I think generally all good tools. And the reason, I'm going to I'll say it kind of broad and then I'll go deeper. Generally, I think all good tools, specifically not for everyone. So when I say generally, when you look at all those things, they're all things that actually just take us closer to what our natural environment would be. So, like being in cold water would not be foreign to most pre-industrialized people. Like that was the water that was available, was cold water. And you had cold air in a lot of places. So it just kind of takes you closer to it. In an infrared sauna or sunlight itself is just something that you wouldn't have been able to escape as easily. So we're built for that. And there's a ton of data that goes into that. There are cold thermogenesis protocols you can look at. There are, if you look at how many papers there are relative to heliotherapy, it's amazing. You just can't get past the physics of living in this universe. And those are ways that we can tap into it that pull us out of a 70-degree, artificially lit room and pull us like back into the real world for a little while. So being in the sauna, getting some infrared heat, being outside, getting actual true photons on your skin, being in the cold allows you to just be able to have a variance or a capacity to your system that you can exist outside of the range between 68 and 72 degrees Fahrenheit. You can expand the range of what you're capable of, and it's fitness for that system the same way you'd have fitness for your muscles. So I think if you're a person that's healthy, exposing yourself to that is great. And it doesn't have to be a cold plunge. It can be, if you're up here where you guys are from, where I'm from, you just go outside, go play outside, be active. In the summertime, you're going to get a bunch of sun. In the wintertime, you're going to get a bunch of cold. But just being able to exist outside of an indoor temperature in an indoor environment is super important.
So it's funny because, obviously here in the summertime, it was a particularly hot summer. It was like 110 degrees for like a record.
Just no rain.
And no rain.
Like cracks in your earth that you're like, I may actually fall through to another country.
Yeah, you were telling me about that in your yard. You had ruts in your yard. Yeah.
Yeah. To a point where I'm like, I hope my kid doesn't run and disappear.
Keep an eye on the dog.
Like, and then you have a rainstorm that drops 5 inches of rain in 2 hours and they're gone. Like it's
just reabsorbs.
It's different than growing up north, which we grew up in Windsor, Canada, so it's different.
My blood's definitely thin though, because you're gonna laugh. I got in the pool this morning. It's like 65 degrees out right now, but the pool is like 55 degrees. I'm getting in there and like trying to run around and but the crazy thing is like if I haven't eaten or if I've had too much coffee or something like that, I get in and it's like, whoa, maybe a little lightheaded there for a second or something. It's like, now I make sure my wife's out there, make sure she can fish me out if I pass out or something.
And if you need to, like you can fly out. Well,
that's right.
Somebody you can go see.
I got someone now that we can.
I was just up in Canada like a week and a half ago, and going into like the hockey rinks in Canada, it's like 32 degrees, just around freezing. So it's like they're not even tapping into winter yet, and I'm like just sitting there like layered up, two pairs of socks on. A little rattled that they don't have like the radiant heaters kicking yet. And my brother's like, it's not even like cold yet. Why would we have those on? And I'm just sitting here, I'm like, my blood is so thin. But again, like it
shows you the adaptability. But again, if you were
that's the point though, if you can adapt to it, and that's what we should be stressing is being able to adapt to the world rather than not. And I think commercially we're tapping into things that are just the ability to have that ability again.
Yeah. That's actually one of the questions I ask people all the time is like, do you get cold when it's below 68? Do you get hot when it's above 72? Because if that's the case, that's just telling me something about your ability to adapt or your ability to regulate blood flow. Are you gonna have these problems if because our office, we like it a little cooler in here. Even as Texans, we like it a little bit cooler in here.
68, we're 65. Like we're moving around all the time. So it's just, I don't want to be sweating on somebody.
Yeah.
So we try to keep it a little bit cooler, but some that, especially like the ones that tend to be more on the stress side, they come in like, oh, it's so cold. And it's just, you definitely see changes in that. Another question kind of you mentioned something when we, we'll pause here for a second.
Sorry about that.
Oh, you're good.
Go ahead.
You're super quick, lightning. So you mentioned again when I was like, hey, just describe the autonomic nervous system and its importance. And I think it's really because again, I think online, social media, there's a lot of people that want to kind of speak very like as they're like an expert on it, and it's like, oh, we need to activate your vagus nerve, and this is going to be the best, like the only thing you need to do. And it's just this idea that it's either one is on and the sympathetic is off, or it's like the parasympathetic's on, and it's just again, you see how kind of butchered it is. Does that bother you?
And it's my biggest pet peeve.
In red here.
There's a great book by Wilfried Janig, who's a German guy, and he he really classified. He's a brilliant guy. Yeah, those ideas were kind of promoted by Cannon and Hess, who knew better, but it was just a way to simplify it, way to try to communicate it on a broad scale. So you spoke to two of them. Number one is the sympathetic system and the parasympathetic system are now what we call reciprocally antagonistic. It's a fancy word for saying it's not like a teeter-totter. It's not like one goes up, one goes down. It just doesn't work like that. Sympathetic nerves and parasympathetic nerves are just types of peripheral nerves. It's just the way they're structured. So sympathetic nerves, the advantage is they have the ganglion really close to the spinal cord, and then they have the ability to be able to have all of these projections go out, which is really useful if you're controlling vessels, because vessels are all over the place. If you had to put a ganglion next to every vessel, it would be maddening. You just couldn't do it. So structurally, it makes sense to pull that ganglion really close to the spinal cord so that you can have all the branches go out. The parasympathetic system is different. It's organized for different things. These are more concentrated organs like your pancreas, your adrenal gland, your kidney. You can afford to send one nerve right next door to that kidney, set up the ganglion there, and it's right there. So it's just relative to what it's innervating dictates the structure of the nerve. So that's really what you're looking at. In both instances, you can give examples where you would have co-activation of sympathetic nerves, meaning like I might sweat and have a high heart rate and have constriction of my blood vessels all at the same time. But also, there could be a scenario where I have activation of parasympathetic organs and sympathetic organs at the same time. Or I can be salivating, which is a parasympathetic activity, and I can have a high heart rate all at the same time. Like a healthy human has the capacity to just have access to a variety of things that they can do. What we see with dysautonomia or anything that affects autonomic systems, when they start to fail, we lose the ability to have specific control. And we end up either with an adaptation or a generalized control mechanism. So for an adaptation, if the autoregulation of my brain doesn't work correctly and I can't maintain blood flow, I can use a high heart rate as an adaptation to be able to compensate for the fact that I can't control blood as well. But if I pump my heart more, I can do better, right?
Which is cool that the brain has that. Like
it's amazing. Yeah. We did without asking. We solve for things. And if it doesn't work as well, we just become more generalized in our capacity, which means the complexity of what we can do is going to go down. And when it gets real bad, it goes down a lot and we get really symptomatic. Like normally we can stand, which is a very complex task. But if that breaks down, generally we have to drop a level of complexity and we can't stand anymore. And that becomes problematic. It's not like a great way to live. So if you can understand it like that, like a movement disorder, same way people get dystonias, the same way people have Parkinson's disease that causes bradykinesia, we can apply those similar mental models to thinking about autonomic systems and it makes them make sense easier. And I credit Dr. Carrick with that, ad infinitum, because if you can look at it through those models, then it makes it easier to understand, like, well, how do we then solve for this? How do we go back? How do we trace this back up as high as we need to go? And how can we see if we can get better at that? Can we get more specific with the movement? Can we do it again?
Yeah, I mean, I think the approach from a functional standpoint, just you went to school with that as like your foundation, and I think that's so unique. And I think it's the same thing. Like when my first semester, I think I did a neurological adjusting course with Dr. Klotzik, and then I had a peripheral nerve course with Dr. Tom Colton, and it's just like. Then you go and you sit down in even if it's a physiology or a biochemistry or kind of the traditional neurology class, you can never look at those courses the same. Like the way you approach everything is, again, you're troubleshooting, it's functional, it's layering in, and it's never on or off and very like simplistic. And I think it's unique. And I know I'm incredibly grateful that the approach is kind of, that's how we were exposed to it and how we layered. And I remember, I mean, what semester were you in?
I was tried 2.
And I'm like, you just need to come and hang out for a morning. We met playing hockey. I think there was all but maybe 5 actual hockey players at the university in Texas. And then there's some like people like, oh, I'll try it. So we're trying to get like a game together, and again, we kind of connected through that. Like, why don't you come to a weekend and just sit in on the Saturday morning of a carrot course? And I think you're going through like cardiophysiology.
It was cardiophysiology at the time. And it was just straight cardiophysiology. It had no relay into with the neurological, let alone autonomic nervous system. And it's just like, we sat in, I listened to that, and it gave me like that first layer of like knowledge. And then when I sat in on that weekend, it was like, just mind blown. And then it just takes that information that you just said. It's like, okay, I got a postural orthostatic tachycardia syndrome, my high heart rate. Let's just do vagal nerve stimulation and decrease your heart rate. It's like, maybe that's not the right thing, and that's going to make that person pass out. It's like trying to just play the teeter-totter game. And I understand the teeter-totter is there for simplistic explanation, but it's really, unfortunately, gotten its grip into traditional medicine, traditional healthcare to educate it that way. And, looking at it from a brain is trying to, from a top-down approach of regulating so that I can do what I want to do. I can go run outside, whether it's 10 degrees below or 110 degrees, and have good function.
So
that's real quick on that first class that you had. When I first started teaching for the Carrick Institute, we had to fill out this basically like strengths and weaknesses form. And they're like, is there any course that you would feel would be the one you would be the least confident to teach? And that's the one I put, was cardiac physiology.
Oh,
cardiac physiology. And so the first course that I taught was cardiac physiology in Harrisburg, Pennsylvania. And and it's just been that, man. So so I'm thankful for that. I don't know if they did it on purpose or if they were just like, well, this is the one we have for you. But man, I worked my tail off to teach that course because I didn't want to screw it up. And then here we are.
Yeah.
Say, I know we're getting we appreciate your time. Do you got to get going here anytime? Like, I got a couple questions that I have that I want to be respectful. Okay, I know family time is coming up here. Kind of going back into like, as our ability to integrate and compensate with the environment kind of doesn't get worse, or gets worse. People tend to be like, oh, I'm just getting older. Right. And again, it's like they just kind of want to like, I mean, I don't want to say offshunt like responsibility, or I feel like you can be empowered or you can kind of give that up. What do you say to somebody? It's like, oh, I'm getting forgetful. My balance is as good. It's just, I'm 50. I'm just getting older. Does that bother you? Does that make you like, okay, I need to turn this light bulb around on this person and get them thinking differently, kind of give them the keys back? Like, how do you approach that?
That's a good question. I guess the way I would tend to think about it would be just to try to solve for like, well, what do they want to do with their time that they have on the planet? And, most people still have a passion to do something, whether it's professionally or with their family or whatever that is. But any of it revolves around the capacity for energy. The ability to have energy really is the thing that allows you to do whatever it is that you like to do. If you want to be, if you want to make a lot of money professionally, you've got to have a lot of energy to be able to stay on top of, to do the work, to have the cognitive capacity, to have the motivation to do it. If you want to, be with your family, how many people talk about, I just want to be able to play with my kids? Pick the thing. All of it is relative to your ability to harness energy from the environment and convert it into usable energy in a person. So I tend to want to think about it as like, well, what do you want to use energy for? And how would you benefit from having more? And then how do we solve for creating a better efficiency around that? And a lot of that is contingent on the way you can move electricity through your body. I mean, that's basic, right? So you can have a full belly full of food with, blood still in the system, but if you shut the energy off, if you shut the electricity off in a body, it's dead. So the ability to do that makes it very simple to look at, does the brain work, does the nervous system work as a primary mechanism for being able to do what you want to do in your life.
Let's our last podcast, well, one of our last podcasts was like mental health. How do you see mental health and dysautonomia kind of overlapping?
That's a good one. A good question for today. So I had this conversation today with a patient. A lot of it revolves around a conversation between depression and anxiety is really where a lot of people live. And on the depression side, sometimes depression is the lack of energy, like we just talked about, just the malaise, the hopelessness, and the not knowing what to do. So if you've been sick, those are common things because you're typically not wildly active. You're lost, don't know what to do. Your life is passing you by. These are things that if you stop and think about can be depressing. So it's a reasonable feeling to have. And then also physically, we look at anxiety. The case we had this morning, she just feels anxious. She wakes up and is anxious for no reason. And we look at that as a difference between like a physiological anxiety, where if you look at the physiology of anxiety is telling you to look around. It's telling you something is wrong, and it's trying to create an attention toward solving what is wrong. And that is like the functional physiology of anxiety. So if you're someone that is going through something, a health challenge, there's a high probability that anxiety is going to come with that. Just de facto, like your body is programmed to do that. Something's wrong. Can we figure out what it is? And there's a hypervigilance that comes with that. And especially if you're sick for a long time, you can get really good at it, really efficient at it. And then it becomes, not just a pathology, but habit. So I think being able to understand that and look at that for a lot of people is really useful to say, maybe there's a physiology behind why I feel this way. And solving for that physiology is probably a very useful place to start. And then you can look at things that are relative to the way you feel about yourself and about the world as secondary to that. But what is interesting is most people have different tolerance of that depending on how fatigued they are. It's an easy thing to say. So if you look at like when people are most anxious or most depressed, it's at night before they go to bed. When they're the most fatigued, it's when people are the most paranoid. It's when people make the worst decisions. It's when kids are the most cranky. So even just knowing that tells you that these things are not just living in your thoughts, but it's in the physiology that's behind it. And I think that's really important for people to be able to understand, but also to be able to use as a marker to come out of it.
Yeah, man, we just had the same thing with a child with sensory processing issues disorder. I'm like, when is it at its worst? When he's fatigued? He's like, oh yeah, it's always at the end of the day when he's tired, stressed. And again, it's like, so this is where we want to start to see the improvement first is, is it that 7 p.m. to 8 o'clock? Is he getting better with what we're doing? Like, that's where I want to see like the resiliency go and improve first. And again, it also is a really good like kind of point, like, look, like the brain can be better, but when it's kind of loses its plasticity to control it, that's what we want to work on, is giving it 2 more hours, giving it better endurance, plasticity, and metabolic support.
Yeah, it's interesting. You talk about we don't want to let that pathway linger for too long because it becomes plastic. And then it's like, oh gosh, now it's a big chicken or egg game, right? Is the anxiety driving the physiological issues? Is the physiological issues driving the kind of psychological aspect of things? And then you throw in that neurological plasticity of like, well, we're anxious. We're good at being anxious. And, you know, you can go sit on the, I always tell people, you can go sit on the beach in Mexico. Are you still going to be anxious? And it's like, yep. It's like, okay, maybe we have a plasticity problem there too. So it's, you know, the physiological feeds the neuro feeds the physiological, and then the emotional side of things too. And, you know, I like the model that you have where it's like people come fly out and it's like, get away from their environment. Like, you know, can you speak to how often like just getting out of the environment might be part of the person's dysautonomic problems?
Yeah, well, it gets you out of the habits that you've created around it. So a lot of people end up suffering for quite a period of time. So what originally is a problem with function, with the physiology, with the underlying substrate, morphs. It turns into a pattern. It turns into like the things you do, the places you go, what your exposure is. Very commonly, we'll have people think about, you know, if you spent all your time, I have a couple people that come to mind, in one bedroom and you were sick in that bedroom, we try not to send people back to the same exact environment they were sick in, because there are so many cues that we're unaware of that point us toward behaviors that are relative to sick behaviors. And they're not things that anybody chooses to do. It's nothing like that. It's just cues that your body picks up on that are associated with feelings, that are associated with actions that can cause us to do sick again, or do injured again. So a lot of times we'll send people home with an idea of like, well, maybe, you know, you reorganize your room, or if you've got the ability to do it, choose a different room in your house, trade rooms with somebody. Can you spend time, you know, some people have gone as far as like moving, and they'll just move to a different house so the memories aren't there and they can start over again. So I think all those things are good, but definitely being aware of the fact that there's going to be cues around, like when I wake up, I go sit on the couch and then I watch this thing and then I walk to the fridge on a commercial and then I do this thing. And then next thing you know, you're right back in the same habits you were in before. But if you can rearrange the furniture, if you can, you know, move things around, change it up, can you build new habits and do things in a way that you know, build on the fact that you've got a new neurology to play with? I think that can be really useful for a lot of people.
That makes a ton of sense. I mean, I think, again, a lot of that stuff, like it's subconscious. It's happening whether you know it is or not. And it can change how you feel without you really realizing it's going to maybe make you anxious. But again, the more plastic it becomes, and again, I think it's hard for the person to see it happening, but as providers, like you can kind of see how these things just now are triggers, or now more things are kind of having the same, you know, physiological effect. I mean, you got any more questions? I think we got to wrap it up. It's getting late up there. It's dinner time up there.
That sun's coming down.
So, what time is it? Is the sun out up there or what?
Well, we get about 3 hours of sunlight a day.
Okay, I mean, that's t-shirt weather.
No, it's actually beautiful here right now. We're lucking it out. You guys are missing out. Windsor would be great right now.
So yeah, I'll be up there in December. This summer, actually, I'll be up there probably for a couple weeks in the summer. But so as we tie this up, you know, what are you looking forward to in the next year? Anything on your horizon? Like, are you teaching any courses? If there's any providers listening, where are you going to be teaching in this coming year?
So we've got some coursework coming through the Carrick Institute. I put together like a big 150-hour course that kind of talks about this at a very deep level. It's the way I think about it. And then you know, we do a grand rounds associated with that, where, you know, we bring people out to the clinic and we go through cases together. You guys were part of that. You see, like, we're really just trying to problem solve together and just get reps in working side by side. So it becomes like a Socratic style of seeing patient. And then we decided this year to do one course in January, which is coming up quick, that's just on POTS. So that's kind of the place a lot of people wade into this territory, and we wanted to do it right so that we're kind of defining what is and what isn't. And then how do we start to problem solve around identifying what is POTS, what's not? What are we actually trying to solve? Is it a heart rate problem or is it something else? And I think that that's pretty rich for practitioners if they're into that. And then we try to spend a lot of time teaching just through YouTube and through social media and trying to connect with people that way. Because I think there's a need for it. I think it helps people. We try to just give a value where people can have a different way to think, to have another lens. You know, someone was kind enough to do that for us in our lives. So trying to pass that along and think about their problem in a different way. So that's the year. And just
leads me to my last question to part with here. How do they find you? So you said you do some YouTube, Instagram. Like if people want to kind of like, hey, look, what this guy's been talking about, Dr. Keiser, it's either inspiring, it's educational. How do they get some more information to kind of watch your videos, hear a bit more from you?
Yeah, that'd be great. On all those things, my name is Doc, D-O-C, Keiser, my last name, so Doc Keiser. And we try to just put things out that we think are going to be helpful. And it helps to connect, just try to think about things in a different way and put a spark in people where they can take action and find a new way to think about things.
Yeah, I always stop and watch your videos whenever I see it, because it's never too long, and it's like, here's a quick blurb that's just like, man, that's impactful.
Pretty face, but even better information on those videos, right?
Yeah, I need to get some AI filters, really do it up. I was on Zoom this morning and I found that you can put a fake mustache on yourself on Zoom now. Did you know that?
What?
Oh, you guys have fake ones on right now? Are you guys both clean shaven and these are just Zoom mustaches?
This is a real deal.
I'm kind of trimmed up. He does the fake coloring though, so it's not as gray patchy on Zoom. There's that feature.
Smart. I'm gonna start getting a mustache, I think. So
yeah, handlebars.
That'd be pretty slick.
Wife doesn't usually like it when I do that. Like, just give it a little shave and leave this part a little long.
I usually do that, and then my wife is, how long are you gonna leave that mustache? How long? I don't like it. You should shave that. It lasts maybe a weekend, 3 days, and I end up just shaving the mustache off. It doesn't last long. My kids look at me funny, like I'm some alien, so I just end up shaving it. So, anyways, I mean, I really appreciate you jumping on. Again, you're just a wealth of knowledge. I love your passion. It comes from the heart. And again, I think the best part is like you're truly in it to help people and change, leave a legacy and make it a better like world in terms of neurological health. So I love it. I appreciate having you on, and yeah.
Absolutely. Thanks, Doc. Yeah. Really appreciate it.
Thank you guys for doing this, and thanks for helping all these folks. And it's good to call you friends. So I appreciate it. Thanks, guys.
All right. Well, we'll talk to you soon.
All right. Take care.